the work is only done if every patient has the chance to receive the treatments that are helping. And Paul, when you think about the different countries that you live and work in, or is there big differences?
Sometimes people are just shocked to know that there's a huge burden of cancer deaths in so-called developing countries or least developed countries, whatever we call them. I would call them post-colonial countries, but they're shocked thinking that, this is not the problem there. It's AIDS, tuberculosis, malaria. Well, it is AIDS, tuberculosis, malaria, and it's also cancer. And I'm saying it's been a huge problem. Let me just tell you what I saw in rural Haiti. And that is a clinical desert, right? So there is not the staff, stuff, space, and systems that we needed to diagnose people with critical illnesses or injuries, and that included cancers. And the more years that I spent between Harvard and Haiti, the more we opened up the doors to clinical facilities, in other words, to water or irrigate the clinical desert, the more cancer cases we saw. And what I saw again and again was even when you have a diagnosis, without linking that to a equity platform with treatment options, you're still going to have misery. And what's more, you're also going to immiserate more families as these patients slowly die. So focusing on access to diagnosis, to prevention, diagnosis, and care has to be a top priority in much of the world today. And some of the places where it's a top priority are probably within affluent countries that are inegalitarian and are marked by deep disparities in timing of diagnosis and access to the best care.
I couldn't agree more with that. And it's true that without trying to pick on the fact that you're in the US, Paul, you know better than anybody here that is an issue in the States as well. The difference in 5-year survival can be as much as 10% or more, which is equivalent to the difference between the US and parts of Eastern Europe. And those differences are staggering, they're long-standing, they're well-recognized, and they are not due to race. If you look at equal access systems such as the Veterans Administration or the Military Medical Service in the States, equal treatment yields equal outcome regardless of race. It is the difference in access to investigation, diagnosis, and treatment, which in the States represents access primarily to health insurance, which we all know has been and remains still, unfortunately, very unequal. But at an international level, this is also true. There are 30 countries in sub-Saharan Africa which, at least 5 years ago, had not one single radiotherapy machine. And radiotherapy is reckoned to be an important part of the attempted curative treatment, somewhere around a half of all malignancies of all types of cancer put together. And so it's not surprising that survival in those countries is low, much lower than in other countries. And as Paul was just saying, you provide the basic services of investigation, diagnosis, and treatment at relatively low cost, and you can transform the outcomes of cancer in those countries. Is that if you look worldwide, economic investment in treatment services of exactly the type that Paul has just been describing, in saving the lives of children who develop malignancies, cancers of various types, over the next 30 or 40 years will return at least 4 times the amount you invest. In other words, saving lives is also good economic sense. It's as simple as that. And the cost of what Paul is describing may be in terms of buildings and staffing and resources for treatment and so on. Yes, it's not trivial. But the returns you get, if you ignore every aspect of the human side of this and just look at the money, it's huge. And we should do it as a global society.
Yeah.
Imagine that you take these powerful tools around prevention, like a vaccine for HPV, diagnosis, molecular level diagnostic platforms that are new, and care, even old school chemotherapeutic agents. You take that, you link it to the systems and support and put it in the middle of the clinical desert. I mean, you can imagine how joyful some of this work is, right? Because there's no example of us massively investing resources in cancer prevention, diagnosis, and care in a clinical desert and then failing. These efforts don't fail. And it should be called global health equity, right? We should
Yes.
for higher aspirations and higher standards of care, especially for those who've been shut out from scientific advancement over the last few centuries. And that's really, and that's where pharma should come in, and that's where basic science research come in. That's where record keeping and epidemiology should come in to show the impact that could have, but also the impact of not attending to higher aspirations has had in the past. I think we'd be well placed to keep our aspirations high, that we want to prevent, diagnose, and treat to cure if possible, whenever we can and wherever we can. And we're a long way from getting there.
That's very inspiring, Paul. Thank you.
I couldn't agree more, Paul. I couldn't agree more.